Thanks, Sue. Thank you for the introduction. So we'd love to talk to you all this evening about glucokinase hyperglycemia. And we want to think about it in terms of rethinking gestational diabetes. So Becky and I are working with North East and Yorkshire Genomic Medicine Service on a midwifery-led project to raise awareness of monogenic diabetes amongst maternity diabetes teams, and specifically to focus on glucokinase hyperglycemia, which we'll refer to as GCK for short because it's quite a mouthful otherwise, within the existing gestational diabetes pathway. So monogenic diabetes is rare. It's a genetic form of diabetes caused by a single gene change in one of over 40 genes. And it's often referred to in the literature as maturity onset diabetes of the young, or MODY for short. So it accounts for 2% of all types of diabetes and 3.6% of diabetes diagnosed under the age of 30. It's estimated that around 77% of cases remain undiagnosed outside of the neonatal period. They're either undiagnosed or misdiagnosed with another form of diabetes, commonly type 1 diabetes or type 2 diabetes. And because of that, patients go through frequently a diagnostic odyssey, which is, a long and difficult journey that they and other rare disease patients will undertake before they finally receive an accurate diagnosis. Sometimes this can be years, sometimes decades. You can see in the image on the screen, on the map, that there is widespread regional variation, both in the number of cases diagnosed and referrals received. So what are some red flags that we might look for to suspect if you think your patient may possibly not have the type of diabetes they've been currently diagnosed with? So you'd be looking for young onset diabetes, particularly if it was diagnosed under the age of 25 years. A patient with diabetes whose body mass index is within normal range, so sort of unusually slim perhaps for a patient with type 2, for example, where there's a strong intergenerational family history of diabetes of any kind, particularly if diabetes is non-insulin dependent. You may also see that they have some congenital abnormalities as well, comorbidities, particularly if it was renal or reproductive tract abnormalities. And there may also be concurrent neonatal hypoglycemia and or fetal macrosomia in the history. So the main monogenic or MODY subtypes that you will see are glucokinase hyperglycemia, GCK, HNF1 alpha, HNF4 alpha, and HNF1 beta. There are many, many others, but those are the main ones. So glucokinase hyperglycemia in pregnancy. So the incidence and prevalence of GCK is 1 in 1,000 in the general population, so relatively common. This genetic change results in a mildly raised fasting blood glucose level that will, of course, have been present from birth. And we often incidentally identify this during pregnancy through GTT mainly, because we're screening a cohort of otherwise healthy people who are essentially young, fit and healthy, and who may not have had much interaction with healthcare previously and just haven't had it diagnosed. And obviously we come along offering GTTs, testing their urine, etc., and we discover it incidentally. The normal HbA1c range for patients with GCK is, as you can see on the screen, quite wide, much higher than the normal range, 36 to 58 millimoles. So people with glucokinase hyperglycemia, they've got the same risk as everyone else in the general population of developing type 2 diabetes. It doesn't put them at more risk or less risk. And the mild hyperglycemia associated with GCK is not associated with an increase in either micro or macrovascular complications, such as we would all be familiar with patients who have type 1 or type 2 diabetes. Every baby of a parent who has GCK has a 50% or 1 in 2 chance of inheriting the same gene change. So you can see where that strong intergenerational family history comes in. Family testing for other family members is not required unless a family member has already been diagnosed as having another form of diabetes, so for example type 1 or type 2, or it's a relative who is planning a pregnancy. So we know that every year so many women are diagnosed with gestational diabetes, and the number is increasing year on year. What we also know is that around 1 to 2-ish% of all women diagnosed with GDM will actually have glucokinase hyperglycemia. So therefore, we can say with certainty that GCK will be present within your maternity diabetes clinic. So you can see the testing criteria, which is laid out within the UK, within England, within the National Genomic Test Directory. So this outlines all genomic tests that are available for NHS patients in England for all conditions, and it standardises the criteria for testing. So it shouldn't be a postcode lottery. So the criteria is quite simple for glucokinase hyperglycemia: a current diagnosis of gestational diabetes, a fasting blood glucose level that's slightly higher, mildly hyperglycemic compared to normal, so between 5.5 to 8 millimoles per litre, and a normal BMI. So if the patient is white, a BMI of under 30, or if they're from an ethnic group where there's a higher prevalence of type 2 diabetes, slightly lower at 27. And then you can offer them the test as set out in the National Test Directory. So once it's diagnosed, what happens next? So as you can see from the image on the screen, which is courtesy of the Genomics education programme, it's showing us the autosomal dominant inheritance that we discussed. So where one parent is affected, every child has a 50% chance of inheriting the same gene change. So management of the pregnancy depends on whether the baby has inherited the same gene change as the mother. The reason we want to know is because of the implication on birth weight. So as you can see from the graph, babies who haven't inherited the same gene change, which is in pink on the graph, can be approximately 0.5 kilo heavier than babies who have inherited the same gene change as their mother. So we can find out whether the baby's inherited this through non-invasive testing. So non-invasive testing is available for 2 forms of monogenic diabetes currently: glucokinase hyperglycemia and HNF4 alpha. So the criteria to offer the non-invasive testing is again outlined in the National Genomic Test Directory, and you can see on the screen it would be again that the mother has been diagnosed with GCK. We can offer the test. There are a few situations where it wouldn't be appropriate. And if it is appropriate, you contact the specialist laboratory team at Exeter who do all the testing in England, and they will send you the relevant test pack, and you can just go ahead and do that. So the management of the pregnancy is guided by whether the baby has inherited the same gene change. So as you can see there, if the mother has GCK and her baby also has inherited the same gene change, there's no increased risk of macrosomia, and therefore the woman does not need treatment for her hyperglycemia. If the mother has GCK and her baby has not inherited the same gene change, which we know is a 50% chance, their baby is at an increased risk of macrosomia because obviously it's being exposed to hyperglycemia as with any other diabetic mother, and you would treat as appropriate. And finally, if the woman has GCK and the baby, we don't know the genotype, either because testing is not appropriate or the patient has declined it, or because she's diagnosed too late in the pregnancy, then you just have to treat as with an unknown genotype. So treatment would be individualized to the patient. And now I'll hand over to Becky, and she will tell us about her lived experience of implementing this testing at her trust.
Thank you very much, Nicola. Thank you for having us here this evening. So whilst Nicola's part of the presentation is very educational, mine is a little bit more me, because this is about implementing my lived experience doing this at Bradford, which we have nicknamed the Bradford Beacon, as we are shining light on Bradford, hopefully. So the first part is, the next slide, please, Nicola, is going to be a map of, well, a large map of the area right in the middle there, Bradford. So Bradford is the 5th largest local authority in England in terms of population size. It has a lot of similarities to Birmingham, Leeds, Manchester and Sheffield. Leeds is the closest to us. We have quite a similar population and similar numbers. The population of the inner city Bradford is a very ethnically diverse area. It is exceptionally deprived in some areas and has some of the worst health inequalities in England, including high rates of infant mortality, early mortality, and long-term conditions. Over 50% of our pregnant population are overweight or obese, so we do have a lot of ladies who have very high BMIs in Bradford. Which, given what Nicola has just gone through the testing criteria, that is one of the areas that we fall down in for testing. And in Bradford, we have around 5,500 babies born every year, give or take a few, which is similar to some of the units in our area. And a massive amount of that 5,500, a massive amount of those patients are GDM. We're looking at about 1/5 of our population are GDM patients, which leads us on nicely to getting started with testing. So when anything is introduced as a new procedure, a new policy, getting started is the hardest bit. So I approach this from a QI kind of standpoint, if you like. So I started it as a quality improvement project with our OMS, which is our outstanding maternity services team, who have been endlessly helpful throughout this. So first point is discussion and communication with your MDT. So you need to be having conversations, and I started by having conversations with our head of midwifery, maternity matrons, our clinical and deputy clinical director, my diabetes MDT, which at Bradford is quite a large MDT. I think there's about 15 of us, antenatal clinic manager, and the midwives who work on the floor in antenatal clinic. I wanted them to be on the same page as me. Why are we doing this testing? What are the benefits? Who are we testing? And why are we testing? What are the benefits, rather? And who are we testing? So keeping that communication open with your team, that is the best point of getting started. So amending existing diabetes and pregnancy trust guidelines and developing a SOP. Now, this seemed daunting to me because our diabetes guideline, like most trusts, it is exceptionally large. It is a little bit like War and Peace. So it does seem a daunting thing to start. However, because there's no NICE or RCOG guidance at the minute with regards GCK, we do have the Diabetes Genes website, which is where we have guidance for this. So that's a guidance in starting your change of guidance. It is a paragraph that I ended up putting into our guidelines, so it's not a huge, a huge portion of your guideline. And the SOP I developed alongside our, between me and Nicola and the wider team for GCK and our MDT, and it's a 1-page SOP. So a doable amount of guideline and SOP. So when I started discussions and communication with the wider team, I missed out some very important people. So the pathology lab and the post-room team are really important to get on board. So the pathology lab, obviously, we're taking samples, we're sending samples. It didn't even enter my head that I would need to speak to these people in the first instance. So now made friends with the pathology lab. At Bradford, we decided that it would be easier for the samples to go directly from me and straight out from me down to Exeter, so it doesn't go to our lab. Now, this will be different for different locations. Everyone will have their own way of doing it, but it's important to have that conversation to find out what's best. Post-room team, logistically, it needs to get from the patient through me and out of our hospital. Our post-room have done it they do it as a recorded delivery for me. They've provided the parcel, the packaging, and you do need to follow some quite strict guidance, which is available on the Royal Mail website. And I believe it's guidance 650 for packaging of samples. So those two people were really important to speak to. So developing standardized review for OGTT and blood results. So at my trust, we have a wonderful dashboard, which allows us to have the, just bear with me 1 second, because I'm having a little.
It sounds like Becky's Wi-Fi's gone slightly astray, but hopefully she's coming back to us.
Sorry, I'm back. I was having a little dip there. The OGTT results. So we have a dashboard that our business analyst team has put together, and that tells me every day how many people are raised, and what those results are. I'm currently working with them to amend it a little bit further so that the BMI results and the patient's ethnic background are on there. Of course, I have been going in individually to records to look at these other details, so that just takes a little bit more time. So we're developing a different way of doing that. So review and analysis of GDM cohort. So I looked back at 6 months worth of data to see what the numbers were going to be retrospectively. And as I say, GDM patients make up 1/5 of our birthing population at Bradford. So I've looked back at those dates, at those figures, and they should be coming up in the next. Oh, so sorry. GDM, as we said, Nicola said, is on the rise. So back in 2020 at Bradford, we had 444 ladies diagnosed GDM. And in 2025, we are currently on track, when we get to the end of March, to be around about 1,000. So that number is just on the up massively. We do have a higher proportion of South Asian ladies at about 60%, lower numbers of Black ladies at 6.7 and white women at 26.7. And as previously said, we do have a high proportion of deprivation, about 53%. So the numbers that I looked back on, which should hopefully be on the next slide, I've got those confused. Next one, please, Nick, that's it. 472 women were diagnosed with GDM over a 6-month period from July to December 2024. 16 of those women met the eligibility criteria for GCK testing, and that represented 3.3% of the GDM cohort within that 6-month period. So that's the numbers that we were looking at for GCK testing. So challenges. So first stop is keeping the awareness amongst your wider MDT. The amount of times that I stop consultants within our MDT in the corridor just to remind them that I'm doing this, or just to remind them that I've just tested a patient, or keeping it fresh in the mind. New things take time to embed. So just keeping that conversation going and making sure that your full team know why you're doing this. And like I've said, who are we testing? Why are we testing them? So specific testing issues within trusts. So initially, I thought that my specific testing issues would be with logistics, postage, getting the samples out of the building, the time for doing the checks and the auditing, and staff involvement and staff getting on board. I was exceptionally wrong. My team at Bradford have been amazing, to use the word exceptional again. They have been exceptional in accepting this. My main area of issue has been, and it is an issue at Bradford, patients accepting care and wanting to access care. So I've had quite a large number of ladies, unfortunately, who've declined testing for many reasons. But yeah, patient engagement has been one of the most difficult. So a lot of ladies have not wanted any further testing, and that was the bottom line. They just didn't want any further blood tests. Some people have declined because they just didn't like the idea of genetic testing. I'm sure some people have maybe not fully understood, and when we've tried to delve deeper, they've just not been interested. So there has been a number of problems for me, which is just something that, you have to have some resilience for and get used to, really. So those are the biggest challenges that we faced, which leads me nicely on to keeping the momentum going and resilience. So if you don't have great resilience, this will definitely develop your resilience skills, as it has done with me. So we have to remember, this is not about the amount of women that we get as a positive result, which has been drummed into me, and I now feel is settled within me. It isn't about the number of women that we're getting positive. It's about the number of women that we are testing. And it's the equality of that test and the availability of that test across the board for all eligible patients. So my resilience has gone up tenfold. And when we put this presentation together, I'd only tested 2 patients. However, I'm now at a whopping 5. I've still not had a positive, but my resilience is ongoing and getting stronger. So we will just keep it going and see where we get to. Sustainability wise, it is exceptionally important. I love that word this evening, exceptionally important, that you are keeping, that you're not a single point of failure. So I was, or currently am to a degree, still a single point of failure. It only takes annual leave or illness for some scaffolding around this to fall down. So I am very keen on training other members of my team. So I have 2 wonderful midwives that work alongside me, and I'm going to be training them in consenting ladies for the test, and making sure that there is somebody there at all times that can complete the consent, can do the testing, and can get it out of the building down to Exeter. So yeah, key to have a number of team members alongside. And then audit, with it being a QI project, that's the way that I approached it. I'm constantly auditing. I'm constantly looking at who we're testing, how many we're testing. If we're not testing them, why aren't we? I'm starting a bigger piece of work soon on ladies who decide against the test, to look into reasons for declining the test. So auditing all the time, keeping it moving forward. So audit is key. And then sources of support. So there are a good few sources of support. So we have the 1 in 6 billion podcast, which is a wonderful listen, and that's available on all podcast platforms. We have our regional community of practice support group. So that is a safe space for us to get together regionally, DSMs, any members of the MDT who want to, come to that can. And it's a troubleshooting area where we can discuss, our wins. And we do have definite fails that we discuss as well, and fall down areas, but we're keeping that, it's about keeping that momentum going and supporting each other through it. The Diabetes Genes website is an amazing resource for all things GCK and all things, diabetes genes. And we also have the Northeastern Yorkshire digital GMS digital toolkit, which we've been working on through this project, to enable people to have a toolkit of resources to go to, so that they've got a starting point, they can cherry pick information and then make their own guidance and SOPs and things like that. And then finally, it is about, the take-home messages. So remembering your red flags. This can appear in family history, test results, or scans. As Nicola said, we are within maternity testing and otherwise mostly healthy population. So it can be found incidentally, but it also can be found in family history. So make sure that you're assessing family history and looking at family history properly. Early risk assessment allows timely testing. So Nicola did mention when ladies get diagnosed later. So the sooner that we can diagnose these ladies in pregnancy, the better. Knowing your own local clinical pathways, and discussing within your MDT. So like I've said a couple of times, keeping that conversation going with your MDT, and knowing your own pathways and how this will fit into your own pathways. And last but not least, when in doubt, ask. All those resources that I've mentioned are available, and I may live to regret saying, but I always say I'm always contactable. My email address is out there, so I'm happy, and I'm sure Nicola will be. And if she's not, I'm nominating you for any questions or queries. And these are the where to go next. So the 1 in 6 billion podcast, as I've mentioned, and the Diabetes Gene website QR codes are available for easy access. Thank you very much.
The 1 in 6 billion podcast is a wonderful podcast hosted by Professor Andrew Hattersley and Professor Maggie Shepherd of Exeter. And they are some of the foremost experts globally in monogenic diabetes. And in particular, series 3, episodes 5, 6, and 7 focus on GCK. But all of the episodes are excellent. Some are a bit of a tearjerker, others are funny. They cover all the different types of diabetes, lots of really interesting research and latest developments, and they're definitely worth a listen. And as Becky said, there's the Diabetes Genes website. That's what it looks like. There's all the, up-to-date information on there, including management guidelines for pregnancy, because as Becky said, currently there's no NICE guidance or RCOG guidance specifically for monogenic diabetes, let alone in pregnancy. So the Diabetes Genes website provides the accepted national guidance in lieu of it being NICE or RCOG.